Okay, let's talk about this interesting case of a patient presenting with bilateral proximal humerus fractures. This was a 20-something-year-old male who presented to the emergency department via ambulance. He had a history of polycythemia on apixaban. He'd had a right above knee amputation and he had a seizure disorder. He was complaining of bilateral shoulder pain. He had no trauma and he had no explanation for his symptoms on repeated questioning. On physical exam, his heart rate was 132, but he was otherwise stable. He had significant bruising over his right shoulder, and there was swelling as well. He had inability or unable to move significantly or range either shoulder. His strength and neurovascular exam from the elbow down was basically normal. Okay, this is the patient's x-rays. On the left side of the screen, which is his right shoulder, you see a surgical neck fracture with the proximal component, basically the humeral head, has popped off and displaced posteriorly. This is the shoulder that's bothering him more. And then on the left side, you see a surgical neck fracture as well. That one is more anatomic with less displacement, and it looks like there's some callus formation, which may suggest that this is a subacute fracture. So let's talk about proximal humerus fractures. By definition, this is a fracture of the humeral head and neck. Represents 4 to 5% of all fractures, so it's actually pretty common. More common in geriatric patients, which that risk increases as age increases. In a low energy mechanism, it's a fall from standing. It's an older patient with osteoporosis or osteopenia. And the fracture is typically minimally displaced because there's not a lot of force vector. In a high energy mechanism, such as a motor vehicle crash, the patient tends to be younger and there tends to be more displacement. Let's talk about the anatomy just briefly. So there's the humeral head, the articular component that can fracture. There's the anatomic neck, which is less likely to fracture. There's the surgical neck, which is the weakest and most commonly fractured. Both the greater and lesser tuberosity can fracture. The greater tuberosity is generally the rotator cuff muscles. And then you worry about the axillary nerve as it courses inferiorly. That's the most common neurovascular injury. On history, patients should be able to describe a mechanism. Obviously, that was not the case with our patient. There's typically pain, swelling, bruising, and loss of range of motion as reported symptoms. On physical exam, they're going to be tender in that area. You're probably going to see swelling and bruising, and they'll have a reduction in range of motion, and typically neurovascularly intact distally. And again, you worry about the axillary nerve. In the ED, radiographs are sufficient to make the diagnosis. CT, MRI, not typically needed. CT is useful if you really need to characterize the osseous fracture pattern, and MRI looking at the rotator cuff primarily, but again, not needed routinely. Management, these patients can be managed both operatively and non-operatively. That decision is going to be made with the consultation of an orthopedic surgeon. But in general, the non-operative patients are going to be minimally displaced and or patients who are poor surgical candidates. Operative cases are going to be 3 or 4 part fractures, which are inherently unstable, and displaced greater tuberosity fractures, which suggests the rotator cuff has plucked off a chunk of bone. In our patient, he also was found to have stable T7 and T8 vertebral body fractures. Stable meaning there was no retropulsion or cord impingement to suggest a nerve injury or a spinal cord injury. He eventually, after admission, admitted that he was abusing alcohol and that he was essentially blacked out. He still couldn't describe any mechanism of injury. The decision was made not to operate on him while he was in the hospital given his comorbidities. About 3 months after discharge, he underwent a right shoulder hemiarthroplasty where they changed out the humeral component with a prosthetic and then left the native glenoid. In follow-up, he was undergoing physical therapy. He was doing well. All things considered, his strength was still quite limited.